you for joining the webinar hosted by ORDI, and this is a Rare Info series, as you all know. And today's topic would be on the functional ability testing to daily care, a physiotherapy approach in DMD. As you all know, DMD is one of the commonest conditions, and this is going to be a very informative session for all of us. Before I introduce the speaker, I'm Kriti Menon. I'm the Senior Genetic Counselor working with Apollo Hospitals, Delhi. I've been working with Apollo for the last 5 years, and prior to that with other genetic companies. Moving on to introducing today's speaker. So today we have Dr. Gauri Krishna, ma'am. She's the
Gauri
head of
Khandekar.
therapy.
Sorry.
Oh, sorry. I got the wrong name. Yeah, so she's the head of therapy service in Synapse, Jayanagar, Bangalore. She's working extensively in the field of neuromuscular therapy for the past 5 years. With that, ma'am, I hand over to you for your presentation. Thank you so much.
Okay, are you able to see the first slide?
Not yet, ma'am. Yes.
Okay. So thank you very much for inviting me for this talk. Thank you, ORDI. As the moderator said, I am working in this field of neuromuscular conditions in last 5 years, extensively with the pediatric neurologist, and we have the whole team in Baptist. So today the topic what we are going to discuss is the functional ability testing to daily care, physiotherapy approach in DMD. So as we know that Duchenne Muscular Dystrophy is a progressive condition. It's a progressive muscle weakness. It happens due to the lack of dystrophin protein, which is again genetically inherited. So what happens is because of the lack of protein, slowly the muscles gets weakened, and finally the main thing what is going to cause is the functional disability. So initially the child will not show that much of problem, but as the disease progresses, they start showing problem in walking. Then first it will be running, climbing the stairs, then slowly it will come to daily walking, and then finally they would be wheelchair bound. So the first thing I want to tell the audience is why we are studying DMD again in a newer form right now is because there are a lot of disease modifying therapies in DMD. So initially now, as everybody would have studied, that the lifespan of DMD and this thing was very less. But now we have a lot of treatment approaches which are increasing the life of the DMD children. And so the multidisciplinary care is very important because we have to give them a quality of life. And how we assess them in their functional ability is what I'm going to talk about. This is a complete physiotherapy approach. So in physiotherapy, the first thing what we do is the assessment using the just a minute, there's some issue. Okay. So there are two things in physiotherapy approach. The first thing is the assessment using the outcome measures, and second thing is the management. So let's start with the assessment. Like how are we doing the assessments to basically to understand the functional ability in the child with DMD. So what is the need for the standardized assessment? That's the first thing. So what we are achieving by doing the assessment is it is helping us to depict the natural history of the disease. Then it is helping to understand the efficacy of the drug. As I told you, a lot of disease modifying therapies are coming. So we are understanding the efficacy of the drug. And then third thing is it is helping the monitoring of the functional status of the child. So the standardized assessment scales are very, very important, and we are using a standardized outcome measures that we will be discussing shortly. And it is not something which is like a subjective assessment of the children, but it is a standardized assessment using the standardized outcome measures. So what are the principles of the assessment? What we are trying to assess is the development and the mobility, the range of motion, because we are checking the range of motion every time. Then we are checking the posture and the spine of the child. Then we are assessing the respiratory function in the child. Then are there any signs of fatigue and pain that we are seeing? Then we are understanding the muscle strength and which are the muscles which are little better in strength and which are the muscles which are getting weaker day by day. That we will understand. And then finally is the function and the ADLs, because ADLs is the activities of daily living that the child is doing every day. So slowly what happens in DMD is, because of the progressive weakness, the ADL, the daily routine activities also become difficult. So that also we are trying to assess in using the outcome measures. So these are the principles. Then these outcome measures, what we are using, they have to be done by a trained professionals, because these all assessments are we are, as a team, we got trained with the international faculties. These are highly sensitive tests which are having a lot of reliability. So we have to know how to do it and get a proper training to do these tests. Then they have to be done at a regular interval. Then only we will get some data regarding the child's status, like whether the child is improving or the child is showing some deterioration, or the child is having the same status since a long time. So it has to be done at regular intervals. And the third thing is, it is relevant. It is this outcome measures are relevant to the age and severity and the ambulatory status. So, for example, if the child is not able to cover the 10 meters in a short time, like for example, in 10 meters test, we tell the child to walk for 10 meters or run for 10 meters. And if the child is getting a long time to just cover that 10 meters, it's a small distance actually, but if the child is getting too much time to just finish the 10-meter test, then we can predict that the ambulatory status is, the child is not going to be ambulatory for a very long time. So it is relevant. So we will understand the severity, and as the age progresses in DMD, the weakness progresses. So the ambulatory, so these tests become very important to predict the ambulatory status of the child also. So these are the tests. Now let's go on the tests. These are the stages, like early ambulatory, late ambulatory, early non-ambulatory, and late non-ambulatory. So as the name suggests, like 5 to 7 years, they are the early they are into an early ambulatory stage. Then 8 to 11, late ambulatory means they can walk, but they are walking with support, or they are just walking a small distance, and most of the time they have to sit in the wheelchair. And then they become non-ambulatory completely, where a little bit walking also for ADLs also becomes very, very difficult. And in the late non-ambulatory means mainly the affection of your pulmonary system and the cardiac system also starts, because for a long time they will be in the wheelchair. So all other complications also we can predict in the non-ambulatory, late non-ambulatory children with DMD. So these are the functional outcome measures what we are usually using in testing the function of the child. The first thing is North Star ambulatory assessment. As the name suggests, if we have to do it in the ambulant children, means the walking children. Then there are time tests like 6-minute walk distance, 10-meter walk distance. These are again for the ambulant children. And there are time tests. Time test means that we have to tell the child to do that particular activity, whether it is a staircase climbing or it is just a time taken to rise from the floor. So we are calculating the time. We are checking the time on the stopwatch, and we are seeing what is the time taken by that child. So these are all tests are mainly for the ambulant or the walking children. Then there are two tests for the upper limb. Upper limb means we have to know the function of the upper limb also, because in the later stages in DMD, the upper limbs are also affected. Mainly the lower trunk and the lower limbs are affected in DMD first, and then slowly as the age increases and the severity increases, the upper limbs are also affected. So there is a test called performance of upper limb, PUL, that we can do it in ambulant and non-ambulant children, walking or non-walking children. We can do it just to understand how the upper limb function is. Then there is one test called motor function measure, which is helpful for the lower limb assessment also, and for the upper limb function assessment also. Then there is Egan classification, EK2 test, that is for the non-ambulant children. Non-ambulant means obviously in the wheelchair, they are bound in wheelchair, and it is like a parent questionnaire or the child's questionnaire, where we are asking the question and marking some scores to understand again the functional ability of the child. So let's go test by test. So the first is the North Star ambulatory test. As I told you, it has 17 items to check, and it is mainly checking your gross motor ability. So the test starts only with standing, and then it goes on walking, then climbing, then it goes it ends with hopping. So that is a higher gross motor skill. So how we are checking it is, each item is scored 0, 1, and 2. So 0 is completely, if the child is completely unable to do it, is 0. If it is impaired or any compensatory movements are seen, it is 1. And if the child is doing it with a lot of ease, then it is 2. So maximum score here, what we are getting is 34. Then let's go on the upper limb. This performance of upper limb, as I told you, in the later stages of DMD, the upper limbs are also affected, and mainly this test is divided into 22 items, and it is checking all the domains like shoulder, elbow, and the distal hand. So the maximum score what we are getting is 74, and we have a specialized kit which we are using for assessing this upper limb function, and specifically developed to track changes in the upper limb abilities, especially as the ambulation is lost. When the ambulation is lost, non-ambulant children, mainly it is giving us a lot of idea about the upper trunk and the upper limbs. Then, as I told you, there is one test called motor function measure. It can be used for many other neuromuscular diseases also. It has 32 items for the patients who are more than 7 years. And there is a short version of 20 items when the child is younger. The child is between 2 to 6 years. So again, there are 3 domains what we are checking here. The D1 domain is standing and transfers, like how the child is standing and how he's doing the transfers. Means the transitions in standing or sitting to standing, all those things. Then in D2, it is axial and proximal motor function. Means again your trunk and your upper limb and shoulder. And D3 is giving us the idea about distal motor functions. Means how the child is having the different grasp and prehension and is able to write, all these things. So here each score is again scored on a 4-point scale, 0 to 3, and they are expressed as percentage. Now comes as a time test. So the time tests are mainly for the ambulant children. The first thing is 6-minute walk test. What we are doing here is understanding the overall ambulatory capacity of the child. Then how is the procedure? The patient walks back and forth around 25 to 30 meters of flat hallway at their own pace. We are telling the child to walk at their own pace and not pressurizing them to run or walk fast or something. If there are rests required in that 6 minute, we are that is allowed, and we are taking the time for the rest also. And then we see the total distance, how much the child has finished. Like if it is 25 meters one way, then we are calculating 1 lap, second lap, third lap, 4 lap, into obviously the number of like 25 into 4 if it is 100 meters, or 25 into 10, it is 250 meters, something like that. So we are checking these laps and how the child is walking, and we are mentioning the distance covered in 6-minute walk test. It's again a very sensitive test. Then let's finish with the 10-meter run or walk test. So 10-meter run test means we are just marking the distance of 10 meters. It is a quick indicator of ambulatory function. Means what are we telling the child? That they have to just walk, brisk walk or run for 10 meters. If the child is ambulant, if they can run 10 meters, well and good. But if the child is not having that much of ambulatory capacity, if they can just walk and finish that 10-meter, and we are getting the time with the stopwatch, we will understand how are they able to will they be able to cover the 6-minute walk test or no. If it is 10-meter walk only, it is getting difficult for them and they are taking a lot of time, then it is definitely indication of losing the ambulation early on. So it is detecting the short-term functional change and including the early sign of loss of ambulation. That's what I just mentioned. And it is correlating with 6-minute walk test and North Star because it is very sensitive to the ambulatory decline. It has high inter and intra reliability testing. So if your child is not able to walk continuously for 6 minutes also, it's okay. The 10-meter walk or run test is giving us definitely a sign like, okay, how the child is going to do as far as the ambulation is concerned. And there are these two time tests. What we use is the time rise from floor. So the child is lying down on the floor, and it is and you are what you do is start the stopwatch and tell the child to stand up as quickly as possible, and we are checking the time measured. So it is again, it is correlating with North Star and 6-meter walk distance. We are understanding the motor strength because as you know that in DMD they get a lot of time to rise from the floor because basically of the knee extensors and hip extensors weakness. So they are, how much time they are taking to come up, that is a strong indicator that how much they have strength, and it is definitely a predictive of loss of ambulation. In Gauer's time, it is the same thing. And here we are basically checking that how the child is using the hands to assist. Because Gauer's maneuver, everybody knows that they are the child with DMD, they will use the hands to push on the knees and thighs to stand. They are not able to do it as quickly as possible, and basically not in a without the hand support. So when they do it with the hand support, it is Gauer's maneuver. And we are checking the time taken again, and then it is what we are getting is it is a prediction for ambulatory loss in DMD. So it is correlating with North Star and proximal muscle strength also. If the child is not able to do this time TTR or the Gauer's maneuver, not at all, if it is not at all possible, then definitely we can think about the losing the ambulation early on. So now one more test is remaining, is EK2. So EK2 is a patient-reported outcome measure. Means the questions are asked to the non-ambulatory individuals. It can be used for other neuromuscular diseases also. So the child is in the wheelchair, and it is assessing covering the domains such as respiratory function, upper limb activities, mobility, and transfers. So, for example, we are asking the individual with DMD, or we are asking the parent how the child is able to do the transfers. Like, is he able to help himself to transfer onto the commode, or how is he using the hands for that matter? How is he eating? And how deep he can take his breath. All these things, all these domains are covered in just an interview kind of a thing. So we are asking the individual, or we are asking the parents about this domains. So here total score is 51, but when the score is more, it is the severe impairment. And if the score is less, as less as 0, it shows the best function. So the child is able to do most of the things. That is the suggestion it gives. And if it is more, the scores are more, nearing to 51, it is most severe impairment. So these are the functional abilities, what we are checking, the functional abilities we are checking. Now, the few things to consider are: some children are less than 5 years, some children are having autistic and ADHD behavior, cognitive behavior, behavioral problems. So yes, it becomes challenging for us to go to conduct all these tests. But we have to quickly, or our observational, as a therapist, our observational skills, they really need to be good, because it becomes very, very difficult for cognitive difficulties and behavioral problems. They are not complying with the tests at all. And sometimes, yes, we have to repeat, we have to give them a lot of positive reinforcement. So other modalities, other things also we need to include while we are doing this tests. So this is our practice. So as on the right hand side, what you are seeing, it is the assessment summary. So this is the assessment summary what our center is using for the functional assessment, and it is giving us a clear idea where the child is. And as you can see, there is a current score and there is a column of previous score. So on the left hand side, all the outcome measures are noted. So there are different outcome measures for different neuromuscular conditions. Now we are talking only about DMD. So whatever is relevant for that DMD child, we will be assessing and we will be putting the scores in this column. Okay, so when the child is coming for the first time, obviously the current scores will be mentioned. If the child has a follow-up visit, then we will see the previous scores also, and we will write the previous scores also, and then we will write the current scores. So this gives the neurologist a clear-cut idea what is the functional ability of the child. Is the child progressing? Is the child deteriorating, or is the child is status quo? Means he's there. So this is giving us a lot of information for the medical doctor to know, to see the effect of the drug also, like whether to increase the dose, or whether to maintain the dose, or whether to decrease the dose. Because finally what we are checking is the functional ability. If the child is doing well, then definitely we can go on the same dose with that particular child. So as you can see, in the first part of the assessment summary, we are mentioning that what are the DMTs, means disease modifying therapies the child is going on. Like, is he taking the steroids? Is taking has he taken any gene therapy? Then any other things for DMD. Then there is a respiratory support. Then what is the functional status? Like, is he a seater? Is he ambulant? Is he non-ambulant? So all these things are mentioned. Then there is a mention of tightness, contracture, deformity also. So this is giving us a clear picture of child's functional ability, and it is giving a clear-cut prediction for the medical management also. So now we come to the second part of the talk. It is, what is the management? Now we just understood what is the functional, how do you assess the functional ability. Are there any questions? Is it going on okay, or anybody wants to ask any questions?
No questions in the chat box as of now, ma'am. I think we'll wait till the end of the session to take the questions.
Okay, so we come to the second part of the talk, is the management. Means, how do I take care of my child of DMD? So then basically now we know that it is a progressive condition. So we have to sorry. So the goals change as the disease progresses, right? The priorities will be different. So when the child is into the early stage, like if we diagnose the child at 5 years, so the goals will be different that time. Then as the child grows a little further, as we checked on early ambulatory, then late ambulatory, all those stages, we will have to see what is the priority. And physiotherapy is only a part of rehab, so we have to understand that it is a complex condition, so we need the support from many professionals. So what we are doing is definitely it is an important part, but it is not only the part of rehab. There are many professionals which are going to be there in the playing their role. So but the main priority everywhere is the function. So how do I help for the better function of the child? So physiotherapy should not be onerous. Then the principles of management. What are the principles of management here is it has to be a goal based. We have to have some goal. Then it should be pain free. It should not be giving a lot of pain to the child. The child will definitely not going to come and comply with any of your therapy approaches. So it has to be pain free. Then it has to be holistic. So as I told, and it requires a multidisciplinary care. So some children might need some kind of other therapies, like for example, if there are behavioral problems, the child is going to require behavioral therapy. Or if the child is autistic, they will have to have some sensory things going on. Or if the child is having a lot of problem in the postural problems like spine, so we have to take care of the PMR. We have to ask the PMR then about the prescription of your wheelchair or your braces, all that things. So it's physiotherapy is definitely important, but we have to see as a whole, looking as a whole is very important. And then it has to be play based, because most of the children are diagnosed in the young age. You cannot just become very strict with them and get it done, because then their compliance will be very poor then. So if you have little play involved in the earlier stages, then the child will cooperate and comply with the therapy strategies more. So it has to be play based. Then for the ambulant children, what are the goals and what are the plans? So here, what the goals will be for the ambulant children is keep them physically active. So physically active, usually the children are very physically active at that moment, but we have to keep them that way. The main goal will be preventing of contractures, because of the progression of the condition, the muscles are getting weaker and replaced by fibrous tissue. So the tightness and contractures are very common. So we have to keep on stretching the muscle, like the stretching routines and use of night print as the plan you can see on the right hand side. Then ROM exercises, balancing exercises through play. ROM means the range of motion exercise, that you just tell the child to move the joints in the complete range, so that the muscle doesn't become tight. Then we have to prevent the falls, try to prevent the falls. Of course, 100% of the time it is not possible, but when the child is really doing a lot of physically, he's physically too active, then we have to prevent the falls, because once the fracture happens, then managing the fracture also becomes a little difficult in DMD children. And then assistive technology and adaptive equipment. When the child is like dependent on the wheelchair, he's too weak. So we have to go on the adaptive equipments and help them to function as much as possible and not to tire them out. So any assistive device or this thing is used, then the child will become more and more independent. That is very important for us. We have to encourage ADL, that is activities of daily living. And low impact aerobic exercises like walking, swimming are allowed. we are not telling them a complete rest or something like that. Definitely aerobic exercises are required, but low impact aerobic exercise, like we cannot allow a child to go on a trampoline, or we cannot allow the child to go up and down the stairs 5 times. Means all these strenuous activities will weaken the muscles. So we have to tell the parents to go for a low impact aerobic exercises. Now, what are the goals for non-ambulant children? So here again, the child is in the wheelchair, so we have to see their stretching definitely becomes a protocol. Means we have to do the stretchings, and using of the night splints is important. ROM exercises are important because to prevent the deformities basically. And then since they're in wheelchair, we have to give them a lot of mobility trainings, then activity exercise and activity in the wheelchair, then assistive technology, again adaptive equipments. Here in non-ambulant children, the scoliosis prevention becomes an important goal, very, very important, because if the scoliosis sets in and if it worsens, then it is a directly impact on the pulmonary system. So they are not going to get that much of lung expansion, and that adds to the complications. So scoliosis prevention is very important, and respiratory management. Then in the plan, basically we are working on spinal mobility exercises and respiratory management. We are giving them some small activities like deep breathing exercises, or just playing with the bubbles, like just blow the bubble, blow the candle, all this simple respiratory activities, so that the lung expansion is maintained. And then here also we are trying to encourage the ADLs. So how it is possible that with the assistive devices, basically we can help them to modify the wheelchair, modify the table, so that they are using the hands effectively, and at least they are doing the ADLs like eating by themselves or writing. Most of the children are very bright, so they are going to school, or they're attending the school online. So giving them encouragement to write or give that again becomes a important goal and important plan. So what are the don'ts in DMD? So in ambulant children, resistive exercises is definitely detrimental to the muscle. We know the physiology, we know the pathology of the condition. The muscle is definitely at a fault. So we cannot strengthen the muscle with using the resistive exercises. Or that's why we are saying no to any resistive exercise, means using the TheraBand, or using the your weight cuffs, or you're using dumbbells. Any kind of resistive exercises are not allowed. Then repetitive functional training exercises, like a lot of squatting or lunges and getting up and down the staircase, that is not something we can do as a training. Then incentive spirometer is again it's a question mark whether to allow or no, but the literature says that intensive spirometer is giving a lot of pressure on the respiratory muscles, and that much is not required in DMD. So we can start with little balloons and bubbles and all those things, and then we can get a chest expansion. Don't tire them out. And eccentric contraction exercises like trampoline. So in ambulant children, I just mentioned that the exercises like trampoline it should not be avoided. In non-ambulant, don't force them to walk, because once they sit in the wheelchair, that is the indication that the anti-gravity muscles are very, very poor in strength. So they are really not able to create any kind of mobility. So don't force them to walk, like walk. That is not possible, because you're increasing the risk of falls in them. So please don't force them to walk. Then exercises goes beyond their muscle power, we should not be obviously using. Then repetitive functional training exercises, resistive exercises, all are definitely same like ambulant. In non-ambulant also, you should avoid all these things. Don't tire them out too much. So this is just a flow chart talking about the management of loss of range of motion and strengthening. Strengthening does not mean that strengthening with the external weight. It is talking about mainly the hydrotherapy, swimming, then activity, simple activity like walking. And management of range of motion means when the child is having some tightness, regular stretches are important. Then positioning you are giving by the night splints, that is very important. Then you can do serial casting. Then you do orthotics. So all these things are basically managing the we are using it for the management of the range of motion. We have to keep as much as possible. Range of movement is important. And strengthening, again, don't go on the word strengthening. We are just making the most of what the muscles, what they are having, and preventing atrophy. That's all what we are doing. But we are not, again and again I'm telling, that strengthening with external weight is not going to help, and it is very much detrimental for the muscle. So on the left hand side again, you can see some stretching protocols. If you want, I can share with you all these things. On the left hand side, as I said, this is ankle joint, knee joint, hip joint, forearm. So all these are the usually what we see is these muscles are getting tight in DMD early on. So all this stretching protocol is taught to the parents, and they are supposed to do it at least twice a day. Okay. So on the right hand side again in do's, you can see all the ticks, all the green ticks, the stretching routine at least twice a day. Then be active as possible. Free body exercises are allowed. Then swimming, cycling, walking allowed. Use of ankle foot orthosis, AFO, at night regularly. It's very, very important, again, to make the range of motion available. Then the daily activities are planned. You should plan with adequate rest. Simple breathing exercises. Exercise have to be enjoyable and pain-free. Then any starting new exercise, before starting any new exercise, consult the expert. Because this neuromuscular conditions like DMD, they are very much, because of their pathophysiology, they are very prone to the damage. So any exercise, if you start, you have to consult an expert that should we go ahead with this exercise or no, because otherwise it will just create a big harm than a good in the child. And if a fall happens and if the child gets a fracture, in case, that time also you have to consult a neuromuscular team, because the protocol followed after the fracture in the muscular dystrophy is different than a normal fracture in case of pediatric cases. So you should always consult the neuromuscular team. And don'ts, again, I'm emphasizing that excessive exercises, activities leading to fatigue, resistance, using weights, dumbbells, bands, not to be done. Don't force the child to practice difficult activities like going up and down the stairs and carrying heavy bags, because the parents think that if I load the muscle more, if I do these exercises, the muscle will get strengthened. But it doesn't happen in the cases of Duchenne muscular dystrophy. It is definitely going to cause a damage in the muscle, and the function what the child is doing, it will be lost. So it's very important not to force any difficult activities for that child, and any resistive exercises. Then things to monitor are changes. You have to see whether the splints are getting checked every time, because if the child is not fitting, if the child's height is increased, the orthosis is not properly fitting, you have to get it checked. And you have to get it completely changed also, because the child will definitely grow in the height, weight. So the splints are something which are supporting, so you have to keep on monitoring whether it is fitting properly or no. Then the joint contractures, as a parent, obviously you will know whether the child is going into a lot of tightness or what. Please, then if that's the case, please again get connected to the team. We will see what to do, how to prolong the joint contractures. Then the scoliosis, once the child becomes more and more into dependent on the wheelchair, the posture, how he is sitting, because usually they will have asymmetry. Asymmetry means the right and left will not be working as a whole, means maybe the left side is weaker than the right side. So what happens is the child will go on that side unknowingly, and that will slowly develop the scoliotic curve, that is a S curve in the spine. And if that sets in, it will be a problem for your lung expansion. So that has to be checked on. If it is there are any early signs, please get checked with the team. Then fall prevention, and then shortness of breath. If there is any kind of shortness of breath or frequent choking while sleeping or eating, that means the child is having some problem in the respiratory muscles. So please monitor this very carefully and get connected with the expert so that we can avoid the complications. Then how much is too much? Like we are saying that, okay, don't overdo it. So how do we understand that? If there is a lot of pain in the joints after exercise, means okay, I have said that walking is okay, but if the child is walking for say 500 meters and he's complaining of lot of pain in the joints, that means we are overdoing it as exercise. So we should not be doing that. Frequent rests are very important in between. Or if the child is cycling and the child is hyperventilating and he's just not able to talk and he's really tired, so don't go to that level. So we have to stop any kind of exercise, that aerobic exercise also, what we discussed, that has to be stopped before that activity should not give him too tiredness or too much of fatigue. Then there is prolonged soreness in the muscle, means the child will just say that it's just it's not exactly paining, but I'm feeling too tired from this muscle and I'm not able to do my regular activities of daily living. That means we have overdone with the exercise or any activity. So just take it as a hint that, okay, then we ask the parent that what did the child do the previous day. If the child is not walking, for example, 6-minute walk test properly, the previous scores are good, but this time the child is not showing that much of walking. So we definitely ask the activities to the parents, that what did he do. So sometimes the child is like traveled for a long, or they have walked in the morning. There was a lot of activity, maybe some with some relatives or something. So if there is a prolonged soreness, definitely we have overdone it. So rest is important. So the rest is the very important thing here. So that you have to check on. Then if it is taking a longer time to recover from the exercise session, that also is a hint that, okay, the child has done too much. And falling increases right after the exercise session. Sometimes what happens, the exercise session is done and suddenly the child feels maybe the soreness or pain and he falls. That means again we have overdone it. And in extreme cases, there is a chances of dark urine also. That also you need to check. Thank you. So this is all about the management in DMD with ambulant and non-ambulant children. So this is the end of my talk. Thank you very much for your patient listening. If there are any questions, please ask.
Thank you so much, ma'am. I think that was very comprehensively said. Every point was very well covered and very, very well explained for that matter. And one of the actually recently, like my personal experience is that recently we have started, some patients will come to us saying that, we want to start a new drug, because a lot of new drugs are coming, and all these assessments are very important to see what is the prognosis of those drugs. Because how is the drug working? How, is it working from them, not working for them, 6 months, 1 year? All of those things. So recently we started reading a little bit about what are these scores and NASA scores and things that you were saying, because as a clinic, in the clinic, we don't really use them. But we started using them recently for assessing, we didn't start assessing, but we started telling them that you should come to us initially, and so we can guide them to a physiotherapist to score these, and then we will have a prognosis if the drug is
Yeah.
procured.
And one more thing, Ms. Kriti, regarding the clinical trials also, they also are saying that, I mean, the prerequisites to get into the trial, we have to have this standard scores. Means they will tell that
Absolutely.
6-minute walk test should be like this. I mean, at least, 300 meters or 200
Yeah.
meters, or, the scores of POL should be this much. So we should be, as a physiotherapist, I'm giving a lot of talks amongst physiotherapists, because these scales not everybody is using, but it is used internationally. Everywhere globally, we are talking only this language. So about the functional abilities. So that is helping a lot.
True. There should be a global standard, or at least a standard set, so that we know where to start, and at least the patients, wherever they go, they have something to start from the baseline and follow up based on that. So, ma'am, yeah, very well explanatory, and I think it's going to be very useful. As and when more and more drugs also come in, definitely the role would integrate, the whole concept of multidisciplinary care would more be, coming into the picture. I think with that, we can start taking the questions. We don't have any questions in the chat box as of now. So if anyone have any questions, yeah, sorry. So there's one question from Mohammed Shah. Can you show some basic exercise for DMD patient on wheelchair of age 14 years?
Okay. May I know how for how many years has he been sitting? Is it like early non-ambulatory, or it is late non-ambulatory? Because they're saying that he is in wheelchair, but since how many months or days or years?
Mr. Mohammed, if you could unmute yourself and let ma'am know that, please.
Okay, 2 years.
Yeah.
2 years. So as I explained in the talk, for the non-ambulatory population, we have to first think about their posture. Because they're sitting for a longer time, you have to see the spine, how the spine is aligned. So if there is any sign of scoliosis, then we have to go for braces. Braces means there is a jacket kind of a thing which you have to use, and that will provide a support, so that the child will not go into more and more S-curve. That is the first thing we have to consider. And then you can do is a lot of upper limb exercise. If the child has the power, let them do a lot of bilateral activities. If the child doesn't have that power, with assistive the parents' assistance, you can do a lot of activities bilaterally, so that you are increasing the lung capacity and you are giving some rib cage mobility in that case. Okay, like going up like this or going sideways like that. And that is something very important, because they are sitting in the wheelchair with a very compromised posture, and the lung expansion is a problem. So that I can tell you. And third thing is, again, your basic ROM exercise, range of motion exercises, like moving the joints from the whole of the range of motion. These are the things I can suggest. And I don't know the power of the child, like what is the muscle strength approximately in the upper limbs and upper trunk. So it will be a little difficult for me to give an exercise program as such, but you should know the principles basically.
Yeah, thank you, ma'am. Mr. Sad is saying that he's going to school studying in 9th standard. So I think, yeah. Now, moving on to the next question, ma'am. Mr. Samir Bhatia says excellent presentation. And if a patient is doing home physiotherapy twice a day, how frequently should they consult a physiotherapy team?
Home physiotherapy means what? I mean, are you just doing the stretches, or you're just doing the free active exercises? Because as far as the physio session is considered, we are not recommending every day going to a physiotherapy department and taking sessions. That much is not needed. Actually, it's not needed. So we are training the parents only to do the exercises at home, or if for stretches and all, the physiotherapist can come home and take the exercise, that is again allowed. But it can be done twice or thrice a week. That is also enough.
Okay. And Mr. Adar Nagar asked, my son is 12-year-old ambulatory going to school, giving him Deflecort 6 mg for 2 months. Should continue. And his weight is 22 kgs. Is it okay or not?
Basically, that's a pediatric neurologist domain, unfortunately. I mean, I'm not able to answer this question because about, I mean, what is the exact question you asked about the type of like the dosage he's asking about, or what is it?
I think so, ma'am. Should we continue? I think, like you said, the neurologist will need to assess based on the weight and adjust the doses
Exactly. So
required.
the standardized assessment scales are I'm giving the score. So if you're going to a neurologist and if you are showing the physiotherapy assessments with the standardized outcome measures, the neurologist will take a call regarding the drug. Because if the child is really doing well, I mean, he's ambulant and he's going and he's doing everything up to the mark, maybe that dose will be maintained. That much I can tell you. But it completely is the call by the neurologist. I'm not the expert in that.
And one more question from Parul Kumari. Which type of exercise is restricted in DMD? Which type of exercises are restricted in DMD, ma'am?
So in the restriction, as I mentioned, the main thing is you are loading you should not be loading your muscle with any external weight. Any kind of weight bags, any kind of sandbags, any kind of dumbbells, or you're using TheraBands, all resistive exercises, equipments, it should not, the child should not be undergoing all that. You can do free exercise as much as you can, or you're taking your own weight, like you're going on the tummy and just, coming up. You are taking your own weight, it is fine. But if you're loading the muscle with the external weight, like example, like 1 kg sandbag or 2 kg sandbag, then it is detrimental. And again, in the restriction is overdoing the exercise. Like, for example, going up and down the staircase, squatting 10 times, 20 times, doing lunges 20 times. That is tiring. That is going to be tiring for them, because the muscle is at fault. Try to understand, the muscle is at fault. So if you're loading the muscle, it is not going to get strengthened. And that is the main fundamental point you have to all the parents should understand, because we have seen in our clinic lot of patients, parents coming with the history that, okay, our physiotherapist gave us a lot of exercises and we are also making him do this 20 times, that 20 times. But no, that is not the solution. Unfortunately, you make the child active, that is there, but don't overdo it, because you're not going to strengthen the muscles beyond a range. I hope
yes,
I answered the question.
Yes, ma'am. I think that's all the questions we have in the Q&A. Anything else?
Anything else, Ms. Chetna?
There's one more question.
There is one more question. Yeah.
Ashwini Murthy. What should be the chronology of stretching and exercises? Start with exercise? Should we start with exercise? Or stretching? Like how should we do?
Stretching. You have to do the stretches, and stretches also should not be like too much painful, because you will definitely start seeing some tightness over the years in DMD muscles. So that does not mean that you are putting the whole pressure and trying to stretch it, because again you will land up in damaging the muscle. So it has to be like, in a pain-free range only, and then you can maintain it in the night splits. That is very important. And sometimes if the child has a little range, we can do a serial casting also. That also helps. Serial casting means the plaster. We are putting the plaster in the stretched position, means it is done by a doctor, and then stretching is done, and then you put the plaster in that to maintain for a longer time.
And Parul Kumari has one more question, ma'am. Any exercise to increase the bone density? Is there any?
Not really, but bone density, basically, the weight bearing will increase the bone density. If the child is completely non-ambulant and it becomes difficult, then we tell them to at least, make them stand with support, or maybe with the tilt table, the standing frame, because you have to, load the joints to get the bone density. But unfortunately, in DMD, the bone density goes on decreasing with the medication and with the age. But then, as much as possible, you can just, make the child stand, even if they lose independent capacity, but you can still make them stand with support.
Got it. Yes, ma'am. I think that's all the questions as of now. Okay, there is more coming, and it's very nice. Okay, she says thank you.
Okay, so anything, if you need like a pamphlet or something, any guidance you need, definitely we are available in Synapse Neurocenter, Jayanagar. You can get connected with ORDI if you need more talks also about regarding any particular topic. Please get in touch. We are ready to help. This is all for the parents. Like, if you have any more questions also, you can definitely connect with us.
Okay, thank you so much, ma'am. Thank you for your wonderful presentation and answering all the questions patiently. And thank you all the participants for joining. I think with that, we can, close today's session.
Yeah,
and,
thank you, everyone.
Thank you.
Thank you, everyone. Thank you, ORDI. And thank you, Ms. Kriti, helping out with the moderation of this session.
Thank you very much, ma'am.
Thank you. Have a nice weekend, everyone.